Welcome and thank you for standing by. At this time, all participants will be on listen-only mode. Today's conference will have question and answer. To ask a question, press star 1 and make sure to record your name clearly when prompted. To withdraw your request, press star 2. This call is being recorded. If you object, you may disconnect at this point. Now, I'd like to turn the meeting over to your host, Ms. Beth Molina. Ma'am, you may begin.
Hello, and thank you for joining our webinar today. My name is Beth Molina, and I am the Quality and System Improvement Director for the American Heart Association. I specifically cover Kansas, including all of Kansas City and Nebraska. Today, we're really happy to join partnership with the Kansas City-based Bi-State Cardiovascular Education Consortium, and our presentation today is entitled 12-Lead ECG Changes that Mimic ST Segment Elevation Myocardial Infarction. This fits with the American Heart Association's effort to improve Stemi systems of care through our Mission Lifeline initiative. In about 2 weeks, you'll receive an email with a link to go into the American Heart Association's Professional Education Center and claim your CEU's CMEs. In addition, this webinar will be recorded and posted on the Professional Education Center with enduring credits. It will also be posted on the Bi-State webpage. Please allow a few weeks for this presentation to be posted and available. Finally, the slides are available to download by clicking on the 3 paperclip icon on the top right corner. It is now my pleasure to introduce Dr. Balaja. He is here from the Kansas City area. He completed his training in New York City at the State University of New York before moving to Kansas City. He's been practicing interventionalism for 6 years. He has an extensive background in clinical cardiovascular medicine and cardiology research. He's been the director of coronary intervention at Truman Medical Center for the last 3 years. He's award-winning teaching faculty at the University of Missouri Kansas City School of Medicine. He's worked over the last few years to establish a Stemi center at Truman Medical Center in Kansas City. Today's lecture is inspired by hundreds of cases evaluated during his endeavor. Thank you so much for being with us, and go ahead.
Good afternoon, everybody. Welcome to the webinar. This was a mouthful of a title, so I thought let me try to make it more simple. And I thought the answer is it a code STEMI? Yes, no, maybe. But sure, 12-lead ECG changes that mimic ST elevation MI. So why do we talk about this? Why is this such an important issue? I want to present this slide to you that builds a nice background. Over the last 30 years, we have seen life expectancy in the U.S. population rise by almost 8 years. And you'll be surprised to see that most, if not all of it, comes from contributions to improvements in cardiovascular disease. And again, in the red, you see the majority of the portion comes from treatment of coronary heart disease. So you can realize what major strides we have made in treating coronary vascular disease and treating STEMI and producing an effect into actual increase in life expectancy in the U.S. population. I want to present this graph because it's a very interesting correlation between scientific advances and how we have improved mortality over the years. As you see, this kind of puts together, overlays all the major medical advancements we have made in coronary artery disease treatment and how that has impacted mortality over the last few decades. And I want to especially point out that yellow box in the end at 1993, that's when primary PCI was proven to impact mortality over fibrinolytics in treatment of acute ST elevation MI. So that's our entire focus here, to treat these patients to get that big mortality difference that we have achieved over the decades. That slide doesn't show up very well. Essentially what it was trying to say is that almost 1.4 million hospital admissions for acute coronary syndrome every year in the United States, and about a fourth of that are the STEMI patients. So we have a sizable population that we treat with our endeavors towards STEMI management. Again, this slide emphasizes why it is still a big problem. As you can see, of all the 3 kinds of acute coronary syndromes, the mortality in the STEMI cases is the highest, and it continues to grow as time passes. A quick graphic here to show you what a STEMI actually entails. As you know, people with coronary artery disease develop a plaque inside their coronary artery. This is a soft lipid core covered by a thin fibrous cap. Eventually, this cap may rupture, and as the contents of the soft lipid core leak into the coronary artery, a clot ensues. If this clot is totally occlusive to flow in the coronary artery, we have an ST elevation MI. Usually in the ER, this is how a STEMI may be triaged. Anybody coming in with chest pain would get an EKG, and if they're convinced that the EKG is concerning, they would call it a STEMI. Often, EKGs may not accurately represent ST elevation MI because certain other factors have not been entertained. The STEMI may end up on the CAT table with no disease, or with further review, you may realize that the EKG is misleading. So this is the dilemma that we're going to try and sort today and understand how to be more accurate in assessing your EKG and your patient to make a diagnosis of STEMI in a timely manner. So as you know, it's hard to ever dissociate the clinical scenario from every test you do. So what an emphasis should be on every patient that is received in the emergency room or is being evaluated for a STEMI is that always put the clinical scenario and EKG together. Your troponins and your imaging are secondary tools that may be used when there are some doubts on the first two, but always the clinical scenario and EKG should be paired together to make an accurate assessment. And you know that we want to do this quickly because time is muscle. The quicker we can treat the heart, the better our chances of better outcomes in the future. And that is made clear by this 2010 paper from Journal of American College of Cardiology, where you see that door to balloon, the time from the patient reaching the ER to the time we can open the coronary artery, significantly impacts mortality going down the road. As you can see, door to balloon greater than 90 minutes versus door to balloon less than 90 minutes has a strict difference, a very significant difference in mortality, with patients with higher door to balloon times doing poorer. Again, the answer should be quick, but don't hurry, because let's not forget, safety is also of prime importance. I'm sorry, I do not know what happened here. These slides looked great when I sent them over, but they seem a little distorted here. I'll try to make sense of that. What this slide was trying to tell us is that it is, by ACC guidelines, a Class 1 indication that once a patient ends up in the emergency room, we have 10 minutes to get an EKG done and evaluated. So that's the point about being quick. And again, the first EKG may be very early. This might be a point where the patient hasn't quite developed EKG changes yet. So if your clinical scenario convinces you that you're dealing with an acute MI and your EKG looks benign, consider repeating an EKG anywhere between 10 to 20 minutes interval to see if there are some dynamic changes on the EKG, and that might save the day. So again, a Class 1 indication to get an EKG done within 10 minutes. And once you've got that, again, remember, put the story together. The patient's history should be consistent with acute MI. There are some exceptions to that, and that's why we'll discuss this today. Certainly in elderly people, in women, in diabetics, and if you don't have good mental capacity, you may not be able to get a good story or correlate the story with your clinical suspicion, and those are definitely harder cases to evaluate. Continue to have those problems with the slides. I'm really sorry, but again, I'll try to go over what this showed. Again, ACC goes so far as in saying that it is a Class 1 indication that you, when you evaluate a patient with STEMI with an EKG in your hand, should look at the likelihood risk of obstructive coronary artery disease. That means get a good history, understand their symptoms, understand their angina and physical findings before you make a decision on an ST elevation MI diagnosis. Everybody knows the familiar EKG waveforms, the P wave, the QRS, and our interesting part of the EKG, the ST segment, which is at the end of the QRS complex, starting at the J point to the T wave. And we'll talk a little more about this. I want to bring at this point a concept in that when we look at ST depressions in patients with angina or non-ST elevation MI, usually they cannot be reliably considered focal to the territory of the heart from where they might reflect. But the good thing about an ST elevation MI is that the EKG is true to the part of the heart where the lead comes from. What that means is if you have ST elevation in corresponding leads, you can be fairly certain of what artery and what territory of the heart is involved. And this little graphic kind of gives you an overview of that, where the septal leads are V1, 2, anterior leads being V3, 4, lateral leads being 1 AVL, V5, and V6, and the inferior leads being 2, 3, and AVF. And this concept is a little important because, A, you know what kind of an MI you're dealing with, what your target vessel is going to be, but it also helps in understanding where to look for reciprocal changes, and I'll come to that in a minute. As you know, ischemia will cause ST depressions. It may cause T-wave inversions that are deep and symmetric. These are suggestive of ischemia. On the other hand, ST elevation with injury is going to have ST elevations on the leads corresponding to the territory involved. And, of course, we've all looked at these graphics before, the smiley and the frowny faces, to try and understand what is a relevant ST elevation. Usually an ischemic ST elevation is convex upwards, which means that it is a frowny face. On the other hand, an ST elevation that is concave upwards may reflect early repolarization, LVH, and so many different things, and we're going to elaborate on that in a moment too. This is the criteria set from the guidelines for diagnosing ST elevation MI, and I kind of want to point this out. What it says is new ST elevations at the J point, 2 contiguous leads, more than 0.2 millivolts in men or 0.15 millivolts in women if we are looking at leads 3, 2, and 3, and in all other leads we are looking at 0.1 millivolts, that is at least one small box of ST elevations. Of course, if it's a little later in the presentation, we may see some Q waves develop too, and these would reflect an infarction. Q waves that are significant are usually at least one small box wide and one small box deep. To sum it up, in ischemia, you're looking at ST depressions with T-wave inversions, and you likely shouldn't see Q waves because that would reflect an infarct. In an ST elevation MI where injury is occurring, you're going to see the ST elevations we discussed, and there may be Q waves depending on the timing of presentation if some infarct has already occurred. On the other hand, in an infarct, the ST elevations may persist, and that might be due to an aneurysmal part that's developed from the infarct, but what's going to be the hallmark of this EKG is going to be clearly diagnostic Q waves in the territory. And this was what I was trying to allude to earlier when I mentioned reciprocal changes. This is one of the very interesting facts about Stemi that can help you confirm an EKG. In certain kinds of ST elevation MI, you can look for changes in reciprocal leads. These are leads that are anatomically opposite to the lead in which you're having an acute MI. And those leads will show a ST depression in conjunction with ST elevations in the injury leads. So kind of want to point out here a lateral MI with ST elevations in the lateral leads. You will see reciprocal ST depressions in the inferior leads, and vice versa. In inferior MI, with ST elevations in inferior leads, you'll have some ST elevations in the lateral leads. Another interesting thing I want to point out here is the posterior MI, or a very high lateral MI, where you may not diagnose that on a routine EKG unless you add some extra leads, such as V7, V8, or V9, more lateral leads to see the ST elevations. But what you can see on the regular EKG are the reciprocal changes, which are ST depressions in leads V1 through 3. So if you suspect an acute MI and you see ST depressions in leads V1 through 3, add extra leads laterally, V7, 8, and 9, and you'll see ST elevations of your posterior MI. Again, these slides have got a little distorted, but again, what it was trying to say was that there's an indication that if you suspect an acute MI, especially a high lateral MI, add extra leads to the lateral aspect of the thorax from V7 through V9, and this is also an ACC guideline. So, we've discussed everything we need to know about STEMIs. This would be so easy if this was all that we had to talk about. We know what to look for in the EKG. We know how to diagnose it. That would typically be the end of the talk. But that's where the fun starts, because we have a lot of pitfalls, a lot of different presentations that can mimic ST elevations that might look like an infarct. And that's what we're going to talk about. So there's a big list here. I'm going to cover most of these conditions in a little detail. Benign early repolarization, left bundle, pre-excitation, brugada, myocarditis, PE, subarachnoid hemorrhages, metabolic disturbances. We're going to talk about all of these in a little detail now. So one of the most common EKG to be thought for an acute ST elevation MI is early repolarization. In fact, it's so common that nearly 5% of the population may have early repolarization. When such a patient presents with chest pain for any reason to the emergency room, this EKG becomes a little hard to interpret. As you can see, there are ST elevations present in the anterior precaudal leads, and with a setting of chest pain, it is easy to be concerned for an ST elevation MI. But if we start looking at this EKG a little more carefully, we can discern a lot of features that can help us differentiate the two. ST elevations in early repolarization are usually concave upwards. As you can see in leads V2, 3, 4, the ST elevations have the concave upward ST elevation segment. Also, the T waves are usually symmetric and concordant, which means in the same direction as the ST elevations, other than in ischemia you expect T wave inversions. And then the distribution of the ST elevations is not very territorial. We were talking that ST elevations represent the territory of the heart. So if it's an inferior MI, expect ST elevations in 2, 3, and AVF, and not in V2, V3, V4, V5, V6. But as you can see in this EKG, there's ST elevations everywhere. So a diffuse distribution of ST elevations takes away from the likelihood of this being ST elevation MI. And then let's never forget that very useful tool that you can repeat an EKG in 10 to 15 minutes to see what an evolution pattern is going to display, which means are the STs going to get worse, are the ST depressions going to get worse? But in an early repolarization EKG, we're going to have temporal stability, which means you repeat this EKG in 20 minutes, a day, a year, hopefully nothing's going to change. That EKG is going to look just the same. Again, we talked about reciprocal changes earlier. So if you're thinking this is an ST elevation MI, look for reciprocal changes. Absence of reciprocal changes would, again, indicate that this is less likely to be an ST elevation MI. One other condition that is very, very commonly missed for in Stemi is LVH with some repolarization abnormalities. If you can look at this EKG, it looks fairly abnormal. There's a lot of ST elevations with deep T-wave inversions to be seen on this EKG. And LVH may mimic these changes by either primary alteration and repolarization of the hypertrophic muscle or relative subendocardial ischemia that might occur due to very high blood pressures, which most of these hypertrophs will have. So how do you differentiate that? Know your diagnosis of LVH on an EKG very well. So one of the most common criteria to use is the Cornell criteria. LVH diagnosed with the Cornell criteria, you add up the total of your R wave in AVL with your S wave in lead V3, greater than 28 millimeters for male and 20 for females, indicates left ventricular hypertrophy. So if you see LVH with the repolarization abnormalities, you know that can be a different reason for that EKG appearance, and this may not be a Stemi. Some other criteria to diagnose LVH as well. Cornell that I just showed you is one of the most common and most used ones, but here are a few more. An R wave that is at least 12 or more in the lead AVL, 12 millimeters or more, or an R wave in lead 1 that is at least 14 millimeters or more. These can be some alternative criteria that you can use to diagnose LVH. There's a few more, and I put that on the slide. When you have copies of these slides, you can look at them. But the three that I discussed are easier to remember, cover most of your LVH diagnoses, and are more commonly used. Another EKG that you guys might have seen that can often get confused with ST elevation MI is pericarditis. The pericarditis is inflammation of the covering of the heart, the pericardium. It can happen for so many reasons. Medicines can do it, radiation can do it, infections can do it, viral syndromes can do it. It can even happen after an acute MI. But pericarditis has a few hallmark features. If you remember these, the EKG becomes very clear. In pericarditis, of course, you're going to see a sinus rhythm, but you're going to see more diffuse ST elevations. Again, they're not going to be so territorial. And what you're going to see is a depression of the PR segment, which helps differentiate from an acute MI. And I have an example here to show you in a moment. This is an EKG with pericarditis. If you see here, there's diffuse ST elevations everywhere, but look at the PR segment. You can see the PR segment is depressed in relation to the baseline, and that would indicate a diagnosis of pericarditis. So once you have pericarditis diagnosed, the treatment modality for pericarditis is very different. We use NSAIDs, we use colchicine, and you can realize that the treatment paths are very different. So diagnosing pericarditis for what it is rather essential. Again, another condition that may mimic an ST elevation MI, and this is a rather more rare condition, but more often thought to be Stemi than anything else, is the Brugada pattern. Brugada syndrome occurs due to a mutation in the gene that encodes for sodium-ion channels in the heart muscle. And what it does, it creates an EKG where in leads V1 and 2, we see these cove pattern ST elevations, which are slanting downwards and lead to an inverted T wave. This is a very typical pattern of type 1 Brugada. If you look at that EKG, it is so typical. Every time you see that, you will not mistake that EKG. V1, V2, cove pattern, ST elevation slanting downwards, leading into an inverted T wave, type 1 Brugada. Well, Brugada is a serious concern in its own right. It's documented that it can come with an increased risk for ventricular fibrillations, and people who are diagnosed with Brugada and who may have a history of VT or a family history of sudden cardiac death are actually candidates to get an AICD. So if you have any of these features, syncope, electrophysiological disturbances such as VT, VF, be concerned about in Brugada that these people could have sudden cardiac death. These people need to be referred for an AICD, but this is not a STEMI. Continuing, if you see this kind of a patient in your emergency room, that they have facial asymmetry, and the emergency room is thinking this is a STEMI, this is a good time to step in. What happens is in a stroke, in a subarachnoid hemorrhage, you're going to see a very abnormal EKG too. Some ST elevations, deep T-wave inversions that look like this. And the reasoning for this is thought to be that when there's a stroke, there's such a large sympathetic discharge from the brain that it causes sympathetic injury to the heart. But this is not a coronary artery plaque rupture causing an occlusion. This is not a STEMI. And the last thing you may want to do at this point is give the patient antiplatelet drugs and thrombolytics, because if the patient's bleeding in the head, the treatment is entirely different. So if you have signs of stroke with a very abnormal EKG, consider the EKGs related to the stroke. The findings that you most often see are T-wave inversions, ST changes, prolonged QT, and very tall U waves. So in the setting of a stroke, please be mindful of this EKG. Another condition that I've seen surprisingly here at Truman a couple of times, especially in the winter times when we have some homeless people who might be brought in, who have been outside, haven't been indoors, have been in a lot of cold, and they're hypothermic, is we see this aberration in the early part of the ST segment. I hope you can appreciate this here. In the early part of the ST segment, you see a little aberration. What these are J waves or Osborn waves. Osborn waves are a positive deflection of the J point that occurs in the setting of hypothermia. And the height of the Osborn wave is roughly proportional to the degree of hypothermia. So if you have a patient that's really hypothermic, you may have very significant J waves that look like ST elevations and may be confused for an ST elevation MI. Here I have a very dramatic example of very profound J waves. If you appreciate your look at these segments, these are large J waves in a very hypothermic patient, but they mimic an ST elevation and can be confused for an ST elevation MI. Rewarming is going to normalize that EKG. So think of Osborn waves in a very hypothermic patient. A common condition we may see in the emergency room, hyperkalemia. Patients with renal failure, they missed their dialysis, or renal failure that's been in development, they haven't started dialysis yet. As hyperkalemia gets worse, we get into the sine wave pattern on the EKG that starts to mimic more and more like an ST elevation MI. Again, do remember in your patients who are on dialysis, they are at an increased risk for coronary artery disease. You should suspect a STEMI in the appropriate EKG, but do check for hyperkalemia when you see these hyperkalemic EKG changes. A quick blood test will answer your question. Treating the hyperkalemia with intravenous calcium and K-oxalate and insulin D50 would be the answer instead of using thrombolytics or antiplatelet agents. I'm hoping you have heard of the condition called Takotsubo. Some may know it as stress cardiomyopathy. What a Takotsubo is more commonly seen in women than men, usually occurs around a very stressful event, a mentally stressful event that leads to a transient akinesis of the LV mid and distal segments. And typically, these are not limited to a coronary distribution, but if these people go for angiograms, usually the coronaries are normal. There is no coronary artery disease. But the EKG looks very typical for a concern for an ST elevation MI. There may be positive troponins too. This would be what an EKG for a Takotsubo patient looks like. This is somebody we had here at Truman. And when we did an LV gram for this patient, we saw this large wall motion abnormality, dilated distal part of the left ventricle. The base is still contractile. The distal part of the left ventricle is akinetic or aneurysmal, and the EKG looked concerning for STEMI. Many a times these patients are hard to differentiate from an ST elevation MI and may end up in the cath lab and get an angiogram that's normal. But that's when we do an LV-gram, we are able to appreciate the true sense of what we're dealing with. Usually these people can be medically managed and usually make a complete and full recovery over time. This is a hard one too. The EKG in a myocarditis patient looks very much like an ST elevation MI. There will be ST elevations, probably even reciprocal changes. In essence, this is injury to the heart muscle, only it hasn't happened because of a coronary artery occlusion. Usually taking a good history may help. They may describe viral syndromes, they may describe drugs or radiation therapy. And a myocarditis that develops after such events is hard to differentiate from an ST elevation MI. Most of these people may end up in the cath lab with clean coronaries, but then the diagnosis of myocarditis comes as a second thought. Usually if we were to get a biopsy, we would see rampant inflammation in the myocardial cells. Causes of myocarditis can be many. I put this slide here more for completion than expecting you to read through it, but what I wanted you to appreciate is look at the various numbers of infections, viral, bacterial, or parasitic, toxins, immunologic conditions, and physical agents that can cause myocarditis. It's a very vast amount of things that can lead to that condition. A lot of people might have heard about left bundle branch blocks and ST elevation MI. There's always been a back and forth about it. Is a left bundle that's new truly a Stemi or not? I think recent guidelines have helped us understand that better. A left bundle is now not automatically considered an ST elevation MI, but we need to tease out some more differences on the EKG to be concerned about it, and that's kind of why I put this EKG out here. This is a left bundle that is new on a patient that we were called for, but has none of the changes that I'm going to discuss in a moment that should concern us by ST elevation MI. So this patient had clean coronaries, no coronary artery disease at all. The changes came from the Augusta-1 trial where 26,000 patients were studied, and they developed a scoring criteria. The scoring criteria is called sarbosis, and I'm going to go over it in a minute. If all three major part of that criteria are negative, the probability of acute MI is really low. They said it was 16%. So here are the sarbosis criteria. I want to read through them, 1, 2, and 3. ST elevations more than 1 millimeter that are concordant with the QRS complex. What that means is the QRS complex and the ST elevations are in the same direction, and ST elevations more than 1 millimeter. On the other hand, I'm reading the last criteria now. If ST elevations are discordant, that means in opposite direction, then they have to be at least more than 5 millimeters. But in leads V1, 2, and 3, ST elevations, ST depressions of more than 1 millimeter would be significant. So ST elevation concordant more than 1 millimeter, discordant more than 5 millimeters, or ST depressions in V1, 2, and 3 more than 1 millimeter. There's a scoring system here. Each criteria has a score attached to it, 5, 3, and 2. What this criteria does put together is scores of equal or more than 3 have a 90% specificity for acute MI. So if you have a left bundle, use this criteria to guide whether you should be concerned about a Stemi or not. So I wanted to put this graphically because it's a little hard to understand. Again, concordant ST elevations 1 millimeter, discordant ST elevations more than 5 millimeters, but ST depression in lead V1, 2, and 3 more than 1 millimeter. These are the three sarbosis criteria. So this isn't left bundle EKG that actually meets the sarbosis criteria. You see here discordant ST elevations greater than 5 millimeters. So by that criteria, it meets that. Also, in lead V1, 2, and 3, we have ST depressions that are more than 1 millimeter. So it meets multiple criteria. So this is an EKG that meets the sarbosis criteria in left bundle. I haven't seen one in the recent years where I've practiced. So this is, all our left bundles that we thought were acute MIs were a lot of overcalling. I'm sure a lot of you have seen EKG leads being placed haphazardly. Many a times I've been present when an EKG is being done, and people may think I'm too obsessive about it, but I'm asking the tech, may I put the stickers for you, please? And they'll look at me funny, why would you want to do that? But here's why we want to get the leads right. Everybody can look at this graphic and understand the lead positions in an EKG, because if you don't get the leads right or you mix up leads, problems can happen. One of the most common conditions that I've seen is a right arm, left arm lead switch, and that will lead to an EKG that looks like dextrocardia. But here's the one I want to point out that's important for thinking about acute MI. A left arm, left lead EKG that's reversed will mimic an inferior ST elevation MI. And let me show you how. So this is an EKG where those two leads have been switched. And as you can see, in the inferior leads 2, 3, and AVF, we are having more Q waves, T wave inversions with a trend towards ST elevation. So this is an absolutely normal EKG on a normal young person with a left arm, left leg lead reversal that now starts raising concerns for an acute inferior ST elevation myocardial infarction. So these are all in the cases that are hard to differentiate from a Stemi case with a little diligence in looking at the EKG, the background of the knowledge of the conditions that produce these EKGs, and a good review of history can help you differentiate these cases from an ST elevation MI. But now I have some real cases that we have collected over the years at Truman that use just this very knowledge to help us reduce our false ST elevation MI calls. So this is a 49-year-old man with chest pain for 2 days. I hope this talk could be interactive, because now I would be asking you, what do you guys think about this? But I'm told everybody's on mute, so nobody gets to talk to me. So here goes. I'm going to do this for you. What this EKG shows is early repolarization, the most common condition that I talked about that can mimic an ST elevation MI. Here's the young patient with chest pain. There's no LVH on this EKG. None of the criteria for LVH are met. This is early repolarization. We can see the ST elevations are concave upwards. There are no discordant T-wave inversions. There's no localization of ST elevations to one particular arterial anatomy. So this is a patient that likely has another cause for chest pain and needs to be investigated. A little digging into the charts revealed an EKG from a year ago. Apparently, I had read this EKG because I can see my name on there, and it looked identical, just the same changes whatsoever. So remember, we talked about no temporal changes on these EKGs. So within a year, the EKG is the same. So had we had a little diligence in looking at the records, we would not have been concerned about this patient being a Stemi. We could have saved significant cost by setting the pager system off and having a lot of people driving to the hospital with a little diligent medical record research. A 57-year-old woman with chest pain and blood pressure for 210/120. So I always think this is a hard one. When the blood pressure is really high, you worry, is it high because the patient is in so much pain from an obstructed coronary artery disease? Or is the blood pressure high that's causing the chest pain? Well, the answers can be figured. First, if we look at the configuration of the ST elevations in the EKG, we can see, again, they're concave upwards, no reciprocal changes, no discordant deep T-wave inversions. And if we treat this blood pressure, as in this patient we did with some IV labetalol, 15 minutes later, the blood pressure is much better, and so is the EKG. And that helped clear the problem. Again, the ST elevations, you will notice, haven't progressed or changed. They are still concave up, still no discordant T-wave inversions, pointing that this is less likely to be a coronary artery disease patient. The troponins were positive on this patient. Well, the blood pressure was so high, probably caused some subendocardial ischemia. We had positive troponins. The patient did go to CAT next day, and as expected, there was no significant obstructive coronary artery disease. A 63-year-old man with chest pain. I think this is an interesting EKG because, I'm sorry, I have to fly too fast. Interesting EKG because there are some ST elevations and some ST depressions too, so easy to confuse this and start being concerned if you have a good story of chest pain. But a little short review revealed, going the wrong direction now. A little short review revealed that the patient had a CAT, a negative stress test not too long ago, had 5 ED presentations for chest pain with the same EKG in 3 months. So I keep telling everybody I talk to, moral of the story is, please review the chart. I know it takes a moment more, but divide your work. It's teamwork. Let somebody look at the EKG, let another person review the chart. If you're concerned about a STEMI, knowing a little history on the patient goes a long way. A 60-year-old woman that we encountered in our emergency room with loss of consciousness, she was in a casino gambling, and this was her EKG. Well, the EKG truly didn't look that impressive. They were more concerned about her loss of consciousness. If the EKG and the clinical story don't match up to you believing it's a STEMI, don't go for it. This was a STEMI that was called, but by the time we got in, she got some oxygen, subsequently intubated. The EKG from previous years were compared, and they looked no different. So we did not suspect this was an acute MI. She was in respiratory failure. I learned the hard way that you can smoke in casinos. I thought smoking wasn't allowed in casinos, but apparently you can. At least in Kansas City, you can. If you go to a casino, everybody's allowed to smoke. So that's probably what happened for her. She was smoking. She probably had underlying respiratory disease, went into respiratory failure. A 51-year-old patient who presented to us with chest pain and palpitations. Now, you look at this EKG, you see a lot of ST abnormalities. The infield leads are showing some ST depressions. There are some ST changes in the anterolateral leads as well. And it's a concerning EKG, but what is also apparent on this EKG is that this patient is not in sinus rhythm and going really fast. This patient is going at a rate of about 150, and this patient is in a supraventricular tachycardia. If you look at the EKG, you're able to diagnose that. Now, if you're going 150 times a minute for a long time, chances are you're going to develop chest pain. The answer to this is not that this is a STEMI. The answer to this would be we need to slow that heart rate down and see what the EKG looks after the heart rate slow, and is the patient still symptomatic after we fix that heart rate. And truly enough, we gave some adenosine to this patient. That EKG normalized, now in sinus rhythm with no ST changes, and the patient's chest pain was gone. Even though a STEMI was called on this patient never underwent a cath, and we were able to save significant cost on that one. Another patient that showed up for us, 44-year-old man with PAD, chest pain, and positive troponins. Now, when you have positive troponins, it's really hard to beat that one because everybody is convinced that this has to be an acute MI when you have positive troponins. But a little research on this patient, we found that a week ago and then 2 months ago, the EKG looked the same, and the troponins were positive then too. A little more detailed history revealed that this patient had suffered from a long viral syndrome. It appeared this was a myocarditis. Treating with some NSAIDs and colchicine fixed this patient's chest pain and his troponins. He did undergo a stress test later that was absolutely normal. Did not need to go to the cath lab. We had a patient that showed up with 36-year-old guy with headaches, chest pain, and abdominal pain. And that's what the EKG looked like. Yes, the EKG does seem to show some ST elevations in different leads. As you can see, there's some ST elevations in the anterior leads, some in the infralateral leads as well. But this was his EKG from 1 week prior. Looked exactly the same. At this point, he had come in with foot pain, not chest pain. The EKG looks exactly the same. This is, if you look at it carefully, this is LVH with repolarization abnormalities. If you total the R wave in AVL, the S wave in V3, you are looking at an LVH diagnosis. 61-year-old woman who presented to us with a blood pressure of 200 by 110. This is a left bundle branch block. The patient did not have a known left bundle before. ST elevation MI was called because the patient was having some chest pain too. Well, the high blood pressure was the reason for the chest pain, and if you look at the left bundle, it did not meet criteria. The Sarbosa's criteria were not met to be concerned about an ST elevation MI in this patient. There was a 22-year-old man with chest pain, and that's what the EKG looked like. As you can see, a lot of ST elevations there in V4, V5, concerning for ischemia in the right setting. But he's 22 years old. Also, look, there are some artifacts on that EKG. That baseline is moving. That ST elevation looks exaggerated. And, And a little closer look will tell you that the ST elevations are in all leads. They're concave up with no T-wave inversions. So this is early repolarization, very common in a young person. Easy to mistake for ST elevations of ischemia or infarct. 48-year-old man with chest pain. Now, this is a very, very typical EKG. We talked about Brugada syndrome. Look at leads V1 and 2, that cove-shaped ST elevation slanting downwards into T-wave inversions. Very typical. Also absent are reciprocal changes. Also absent are changes in any other leads. This is a very typical pathognomic look for Brugada syndrome. If you look at a Brugada EKG like this, these are not, it's a whole different treatment modality. What they don't need are thrombolytics and aspirin and Plavix or Brilinta. 41-year-old man who had a recent viral syndrome and now showed up with chest pain. Classical EKG for pericarditis. Look at the diffuse ST elevations in leads 1, 2, 3, 4, 5, 6. It's everywhere. And you also see PR depressions. If you appreciate right here, I'm hoping you can see the pointer. Look at the ST depression, PR depression below baseline right here. And you can appreciate that in more leads, but it's just most marked here. This was a 60-year-old woman who showed up with chest pain. The usual suspect. It's a left bundle branch again. A left bundle branch block that was thought to be new. A Stemi was called. We came in. We evaluated the EKG one more time. None of the Sarbosa's criteria are met. Her chest pain was more musculoskeletal, resolved with some pain meds, and she did fine. A 51-year-old man with chest pain and swelling. Again, the EKG has hints of having LVH. Again, a chart review revealed multiple EKGs with LVH and early repolarization in the previous few months. We did not have to take this patient to the cath lab. 44-year-old who came to the ER with a blood pressure of 200 by 110. He came in for suicidal ideation and depression. The EKG looks concerning. There's ST elevations in leads B1 and 2. There's ST depressions in the inferior leads and lateral leads. Well, if this patient was truly having chest pain, I'd be concerned. Unfortunately, for the ER, the patient was called for a Stemi when the patient was having no chest pain. So that's hard to convince. Code Stemi that has presented to the emergency room with no chest pain, so be suspicious if there are no clinical features. Remember, your clinical story is very key. Always try to associate that with your objective testing. Your EKGs, your troponins have to fit the clinical story. So what can we do to reduce false activations? It's a burden that exists everywhere. I think it's not possible to entirely eliminate false activations, but by recognizing the conditions that mimic ST elevation MI, we can truly reduce this burden. It's a significant cost to activate a Stemi, have the whole team come in, take the patient to the cath lab, spend a lot of equipment doing the case, when we could have, with a little chart analysis, with looking at the EKG better, understanding different conditions, have avoided such a call. And not only is it just the cost, it is the risk to the patient too. Getting a procedure, an invasive procedure that could have been avoided. Huge risk of stroke, risk of clots in the leg, risk of bleeding, infection, risk of kidney injury from contrast. We come up with very significant risks in a procedure that could have been avoided. So always try to fit the EKG to the patient. Get the clinical story, put the EKG together. Do an old chart review. I know people are very rushed when a Stemi happens. Make it teamwork. Ask somebody to help. Look at a chart, look at the EKG together. Divide and conquer. Two people can do that. But again, remember, you have 60 minutes to get this patient to the cath lab. So be quick, but never hurry. But in the end, it's teamwork all the way. Whether it's the ER, whether it's the cath lab, whether it's people in between who are evaluating the patient. If we can put this together with the knowledge we have, we can make this a safe process for those who need it and avoid the unnecessary procedures for those who don't. Thank you so much. You've been a wonderfully quiet audience because all of you are on mute. But I had fun talking to everybody. I'm open to any questions at this point. Thank you.
Operator, can you give the instructions, please, to open the lines?
All right. Thank you so much, Ms. Molina. To all of the participants, if you'd like to ask a question, press star 1 and make sure to record your name clearly when prompted. To withdraw your request, press star 2. One moment, please, for our first question.
I have a question while we're waiting for the questions to come in. This is Beth. But there at Truman, does your ambulance do the EKGs in the field?
They do
in the Kansas City
field. They do not have a way to remotely transmit them, but they do them in the field, and if they're concerned about an ST elevation MI, they will transmit that information to the ED while the call that they make while they're coming in with a STEMI. So in that case, the team is alerted. Team will stand by, ready to go as soon as that EKG is confirmed in the emergency room.
Okay. So when it comes in, if they send it to the emergency room, is it the emergency physician that reads it, or is it immediately then sent to a cardiologist to read?
So we have a system where the emergency room physician is going to be the first person to read it. If he has a concern, we have remote access available to have a cardiologist immediately review. But I will tell you, in reality, what happens is when we have a patient coming in by the ambulance that's thought to be a STEMI, and we are aware that this patient is coming in, we're already all set to look at that EKG. The cardiologist is logged in waiting to look at that EKG the moment it comes up in the system, and it usually happens fairly simultaneously, and we are talking all the time. So that's usually a very good way of handling a STEMI patient. That little forewarning gives everybody a chance to be ready to evaluate and decide what to do in a team fashion rather than one person making the call.
Okay. Well, thank you. I just know when you start to look at all of these reasons why you could it not be a STEMI, I'm like, oh, my goodness, I think someone else should look at this.
Beth, there's also a question in the queue.
Yes, please.
Okay, I'll read it. The image you showed for correct lead placement showed V1 and V2 as being located in the second intercostal space. All resources I have seen and in my training indicate those two leads located in the fourth intercostal space. Is there disagreement in the literature around this?
No, there's not a disagreement. The classic V1, V2 are just below the notch, which would be somewhere between the second and third intercostal space. Again, those two leads, one intercostal space above or below, won't make a difference in a big way in diagnosing an ST elevation MI. The right positioning of the leads from the literature that I have grabbed is all in just below the notch, which would put it somewhere between V2 and V3. The rest of the leads do engage in lower intercostal spaces. The leads V3 through V6 are going to go into lower intercostal spaces. So I'm not sure, is that a confusion? Is that what we're mistaken it with?
I'm not sure if the person that wrote the question wants to come. I'm not sure, operator, if you have anybody in queue or if that person wants to comment verbally.
All right, at this time, we don't see any questions on queue. Again, to all of the participants, if you'd like to ask a question, please press star 1.
Yeah, while I'm waiting for questions, again, one or two of the things that I really want to emphasize. If you are concerned about a STEMI and your EKG does not support your clinical concern, repeat an EKG. Wait 10 minutes, 15 minutes, repeat an EKG. That is a very, very handy tool. We often forget to do that. Repeating an EKG will make things very clear. If there's no progression, no change in the EKG, the chances are that this is less likely to be an ST elevation MI.
Are there any questions, operator?
Yes, we do have a question from Tan Kinker. Sir, your line is open.
Thank you, Doctor, for presenting for us. I was actually the one that asked the online question there. And it was just a question about, I guess, I was a EKG tech and then a paramedic, and in our training at both facilities, it was fourth intercostal space, and they were pretty picky about that, and the cardiologist there was picky about that. So I just didn't know if there was differences.
I'll need to do research on that. If you can pass your contact information to the coordinator, I will look that up and answer you in detail one more time. But this is what I have picked up from a couple of sources that are on ACC. But if there is any precedence for allowing a variation in that, I will look it up and I will get back to you.
Okay, thank you so much.
Thank you.
Here's another question that you have. Do you ever have two cardiologists that disagree in the reading, such as a diagnosis of STEMI versus non-STEMI, and what do you do then?
Yeah, no, absolutely. That is an interesting question. I would say in the situation of the STEMI, we have a protocol to defer to the interventionalist to make the call. Usually, the interventionalist call is a one-person decision to call the STEMI. The disagreements may happen probably at a point where we have EKGs that are borderline or have confusing elements, in which case what I would say is that, the answer is not clear. There are times when you need to resort to secondary testing to confirm your ST elevation MI, and that's when bedside echocardiogram may be helpful to look for wall motion abnormalities. And sometimes these patients may need to go to the cath lab because the EKG is not clear enough. The symptoms and the clinical picture is concerning. Hopefully a bedside echo has been done, and if that's concerning too, we may have no choice but to clear it out with a cardiac cath. That's why we will never be able to 100% eliminate negatives in the lab for STEMIs that we take to the lab. But what we hope to do with understanding all the other conditions that mimic ST elevation MI is reduce some obvious patients that could have been weaned out earlier in the pipeline.
Thank you.
Are there any final questions in the queue?
Oh, we don't see any further questions on queue, ma'am.
Okay. Beth, do you want to do the...
Sure. Let's see. Can we advance? Let's advance this here. All right. Thank you very much for presenting that. That was very, very interesting. And Lori Wayne, we thank you for setting all of this up, and the Bi-State Cardiovascular Education Committee for the presentation. Just as a reminder for those that are still on, you will get an email in a couple of weeks regarding your CMEs and your CEUs. The webinar will also be posted on the Bi-State website and the AHA's Professional Education Center. If you have any more questions or want more information on Mission Lifeline, we've listed the directors with the different states, and you can contact them if you have any questions. You also,
if you can grab the contact information for the person who asked the question of the lead placements, I would like to revert back to that gentleman. Also, I wanted to say a big thanks to Lori Wayne, who has been instrumental over so many years in making the STEMI program here at our Institute a success, and this lecture truly wouldn't have been possible without her.
Yes, I agree. Thank you. Actually, we have one more question here that came in.
Absolutely.
It says, is there any benefit to keeping blood pressure slightly elevated during an MI to help perfusion on a coronary artery?
No, there's been no data to prove that increasing perfusion pressures helps in an ST elevation MI. It's a situation of plaque rupture. The plaque rupture needs to be treated. In fact, the shear pressure from very high blood pressure can cause increase in the plaque rupture, so we want to manage extremes of blood pressure as best as we can during the case. But again, no evidence to support increasing perfusion pressure beyond normal blood pressure in an ST elevation MI to help with perfusion. Of course, if we are dealing with a hypotensive patient and we are dealing with hypoperfusion, then we are dealing with a whole different matter, and we want to raise perfusion pressure. In that case, you would use medical means to augment the blood pressure using inotropic agents, balloon pump, or other support devices that may be needed. But at normal pressure and blood pressure and beyond, there's no further advantage, proven advantage to augmenting perfusion pressure.
All right. Well, it looks like that concludes your